Hi friends, today we'll be discussing related to OPS, that is OBGYN and paper 1. So firstly we'll see what university has given us the pattern. So they have mentioned about this Bloom's taxonomy. We'll see what is Bloom's taxonomy, and these are the major 5 topics, and the proper explanation of Bloom's taxonomy is already there in one of the videos which I have explained in the same channel. You can go and watch it related to Gynaec. So okay, this is what is given by the university. Based on this, let us break down and understand what they are expecting us to know from ops. Okay, so if you see the number of questions per section, so you can see that there are 5 sections in total. So the major sections which are for our understanding, let us consider this section as pregnancy related, proper, and this is labor, and this is after labor. Okay, to prevent conception, basic knowledge. Okay, so this is how broadly we can come to a conclusion what is the basic thing they are expecting to know from us. So you can see that these are the most important topics. That means you are expecting 6 questions, and also these are the only 2 10 markers which you can expect. So this is an overlap topic between with ops and gynae as well. So this is one of the topic which you are studying from PETS. So this is the topic which you are studying from second year. So we'll see how to plan and how to go about it. Okay, so according to part 1, part 2 and part 3 and part 4 and 5, these are the chapters which are there in Datta. Okay, so here you can see 1 to 9 all chapters comes under basic obstetrics, and 10 to 21 except 13 and 14 comes under proper ANC. All those things comes under part 2. So this is part 3, and these are the questions in part 4 and part 5. Okay, now based on this we'll see how to go about it, how to study. Okay, so first let us predict the paper. So as per the recent trends, we can see that 2 10 markers will be asked from labor or proper pregnancies as such. So in the medical, basically they are asking from the medical disorders of pregnancy. So what do they expect? Either GDM you can expect, multifetal gestation you can expect, PIH you can expect, APH you can expect, anemia you can expect, RH negative pregnancy you can expect. Okay, so having a sound knowledge about all these things, I'm sure you would have done an extensive discussion during your posting as well. So that is what they are expecting you to know, and also PPH. Second question is basically related to labor or something to do with abortion. Okay, you will get questions basically in these two. So 5 marker 2 questions will be based on something of 10 marker itself. One question will be something related to labor. It might be deep transverse arrest or something like that. One question related to pupillium will come, and one related to MTP, and one related to your basic anatomy physiology. That is this part 1 ka 1 5 marker is sure. Okay, then one question related to COMED will definitely come, or COMED bar neonatology. Okay, you might get an KMC or maternal mortality rate or captive sexidarium, something related to that. Okay, and one more question related to your deep transverse arrest. Here you might get questions like indications, okay, partogram, something like that, but here you will get a question proper. Okay, so 11 and 12, now coming to 3 marker. 3 marker itself is, as I told, they aim to test your basically in a surgical paper they try to test whether you know instruments or any surgery ka indication, contraindications, or any drug ka adverse effects, or any drug ka use. That's what their aim is with pre-para testing. One something related to perineal tear or any regimen like pre-charge regimen they can ask. Diagnosis related to pregnancy also they might ask. Related to pharmac, one things will be asked. 1 or 2 questions related to your investigation or contraception might come. One question, as I told, related to surgery can come. 2 questions from labor and 2 questions from complications of any of the medical or surgical disorders of pregnancy, plus one definition. For example, definition of PIH, definition of GDM. How do you call? When do you call them as that? Is what we can expect. This is in total what is the proper paper distribution for your obstetrics for 100 marks with 10 MCQ, which I'm sure you can do it on the day of exam. Okay, this is what I would like to say at first. So coming to proper, so first our plan of action will be, let us finish part 2, let us finish part 3, then let us go to part 4 and come back to part 1, because I am sure at the end of I'm sure you would have known very basic of all these things. That's what is there, and many doesn't have any RS question. So first we'll finish 2. After pregnancy, what will happen? Labor. After labor, what is the phase? It's preparing with the fetus being a neonate. After that, to prevent it, we have contraception related thing, and also to know the basics, we'll go with part 1. Okay. So these are the topics under your Datta or Singhi. These are the topics which are present. So you can see that almost 3, 6, 7, 8, 10 topics are there, out of which you will get 6 questions. So based on our statistical analysis, we feel the things which are clouded are the most important, and this is where you get your 10 marker. Okay, this is the double liner should know. Okay, but this is expected to know. So make sure, even while writing, I made sure that this is not this is there in a proper order, but in the notes I have given in a order where you can just study and go. Okay, so this is the order which we will follow. Make sure you follow the same order so that you don't waste a day before exam. So first, without wasting time, we will jump to part 2 of your obstetrics, and let us see what are the questions which they are expecting. Okay, following next 5 chapters are the most important thing. Firstly, we'll talk about hemorrhage in early pregnancy. So what does hemorrhage in early pregnancy has to say? Only 2 things. One is abortion, or it is something to do with your GTN. Okay, these are the only things which should come to your mind. So basically, we'll give you a concept map at the starting point of it, because it's all based on concept and flowcharts. Make sure you have your flowcharts in your book, so that you just revise and you have to just go and present it on the day of your exam. So firstly, let us know the concept of your abortion. Okay, firstly you have to check for os and also measure the cardiac activity. So if the os is open, so you and after that, this is what per vaginal examination. This is per abdominal examination. Okay, both the side. So during per vaginal per speculum examination, sorry, it's not per vaginal, it's per speculum. So when you do that, and if you see the os is open, you have only 2 differential. Then you need to see the uterus size. So if the uterus size is smaller, that means something has escaped, so it's an incomplete abortion. But if it's equal, that means the process of abortion has started and you cannot stop it. What does inevitable means? It will occur, correct? So it will occur. Okay, next you have to see so these are the only 2 differential you will have based on if the cervical os is open. Now if the cervical os is closed, now we have to look for uterus size. It can be smaller, or it might be equal, or it might be then you have to check whether bleeding has stopped or not stopped. Okay, so if it's equal, what does it mean? So it means that it's a threatened abortion. So here it has not started, so you can save this abortion. Okay, but if it's already smaller and the bleeding has stopped, that means the process has been completed, so it's a complete abortion. And if the uterus size is smaller, and with there are features of a kind of and fetal cardiac activity is absent, that means it's a missed abortion. Okay, and at the end, if the baby stays there without removal, then it will lead to septic abortion. So this is what the basic concept. So based on this, we'll jump to our 10 marker, 5 marker kind of thing. The one thing, this is also an overlap with gynae, so I'm not discussing much here. The main aim of this video is to show how to study a day before exam, so that you just present it in the same way what has to be presented, and come back, so that you waste less amount of time in the rest of the things. Okay, so firstly we'll talk about ectopic pregnancy. We know all that always pregnancy occurs in the normal pregnancy occurs in fallopian tube. If it occurs anywhere outside the fallopian tube, then it's called as ectopic pregnancy. So what are the etiology? That means something has happened in the your fallopian tube. So it might be infection, or it might be something related to contraception failure, or these are the other causes. So how does the patient. And also one more question is, what are the causes of bleeding PB? One more important thing which I would say you, whenever you are talking about OBS, make sure while writing causes divided into maternal cause, fetal cause and placental cause, so that If it's a 3 marker, the broader classification will itself fetch you 1 or 2 marks. Based on that, you can definitely fill in the causes which has to be filled. Okay, so these are the causes of bleeding PV. I don't think you have to say always while talking about bleeding, what is the two things we will divide based on surgical, traumatic, non-traumatic. So based on that, these are the causes in gynae, and in obstetrics you can talk from A to Z about from the starting of pregnancy till the end of pregnancy. These are the clinical feature. Make sure you have to classify it accordingly, subacute, acute, and if it's unruptured, and also when it's ruptured you will have signs of shock. Make sure you know that, and also mention about the trad. I'm not discussing anything here because I'm sure you know it. Okay, make sure you underline the examination ka part of thing. And what is the major principle here? It's management of acute ectopic pregnancy. And if the patient has already gone into shock, you need to resuscitate the patient and do an emergency laparotomy, and also you have to start shock protocol. And the management part I have uploaded in the last part. Make sure you stay till then, so that we'll revise all the flowchart which are important for the exam at the end. So what is the major aim? I will just write the 3 main aim in the management. First thing is, if the patient is already in shock, start shock protocol. Second thing is, you have diagnosed it as ectopic, diagnose whether it's ruptured or unruptured. If it's unruptured, you can either go with medical or expected management. But if it's a ruptured, there is only surgical management. This is the broad idea. So expected in the sense you will plan when to start the medical. Okay, so based on that, there is a flowchart at the end. Make sure you stay there then, so that we will revise the flowchart. So what do you do in an unruptured tubal pregnancy? We'll check whether after the medical we will check whether expectant management can be done, and if not, we'll go with salpingectomy or ostomy. Okay, again molar pregnancy I will explain you at the end. So that again here what you need to do, it's basically about monitoring beta HCG. I'm giving you the core concepts here. At the end we'll revise it all, so that everything is in your head. Okay, as I told, what is a missed abortion? The fetus is already dead. Okay, these are the clinical features. And what is the complication? Again, while writing complication, what are the three things which you'll mention? You'll write maternal complication here. So here, since baby is already dead, you need not mention about placental or fetal. Again, maternal complication, you can just mention about obstetric complication and gynec-related malignancy. Gynec-related. Obstetric, again, what are the things? Or generally, she can go into sepsis. All those things you can discuss. Then gynec, if you don't read it, she might have bleeding and she might go into shock. Okay. Management, again you need to check for size. If it's less than 12 weeks, you can just manage medically and wait, do an expectant. But if it's more than 12 weeks, you have to induce labor by giving oxytocin. Okay, I've discussed the concept. Now I'm placing everything into the same pages or same same part, so that you know what to revise a day before exam. What is septic abortion? As I told, when it reaches the systemic part, so that you have all the septic kind of clinical feature. Make sure you study the grading first. So what are the 3 grades? You have only 3 grades. First, remember first one and last one. Always while remembering the classification, always first one and last one at the one first, because firstly it will be localized, and last it will be a general peritonitis. Second stage is what is next to it. Okay, so basically you have to remember like that. What are the investigations by aim? It's you have to act very fast. So you have to do blood investigations, and you have to look for any you have to take and do the culture, and you have to look for any metabolic or electrolyte related complications. So these are the immediate and remote complication. Make sure you write about this. I'm not explaining because it goes in the same order. In the complication, again divide and write. Okay, so these are the management which you need to do. First is control sepsis, and if she has already gone into shock, or start or on shock protocol. Okay, which you need, same which we had discussed earlier. So based on this, you have to these are the major important thing which you need to discuss. Okay, Before starting, you start them on a broad spectrum, right? So we'll start with this broad spectrum antibiotic. This is an important 5 marker or a 3 marker. What are the causes of first, according to SRM 2013 ka definition? The definitions are important because they are a part of 3 marker. Okay, so I have just mentioned it what is there in the book. So basically, you need to have what is. I'll just mention the important things. Okay, 2 or more spontaneous abortion documented by either ultrasound, sonography, or histopathological examination. So, what are the etiology? So, first divided into first trimester abortion and second trimester abortion. For second trimester, you can remember AC, that is anatomical abnormalities or cervical incompetence, and here you can remember it as IH. Okay. So it might be due to immune factors, APLA and inherited thrombophilia. Then A, that is acquired. Basically, you have to remember about the hypercoagulable states and genetic factors, and also endocrine and metabolic related. Okay. Then what are the investigation? Again, you need to do investigation to find out the cause, and also you need to do investigation to prevent the abortion in the next time. So basically, based on that, write the aim of investigation based on the etiology, target everything, and make sure you write it. So what is the treatment? So basically, if it's a cervical incompetence, we will be discussing further. You need to do that. If it's an anatomical thing, then you need to go with anatomical correction. Then if it's a chromosomal anomalies, obviously you need to do a genetic counseling. And also for during preparation, you can give progesterone therapy to stabilize the uterus. Okay. Then what about cervical incompetency? So what is happening here? The cervix is getting dilated on its own. So investigation, these are the thing which is present in Datta. I will request you to read it, but don't mention it, because if it's a 10 marker you can mention, but whatever was there I have just mentioned it. Again, definition wise, this is the history part. So diagnosis wise, I have just written the same thing which is written, but make sure this is the main thing which you will mention. So in the sonography, if the cervical length is less than 25 mm, or you can see this kind of sign, that is incomplete Y, V or U-shaped cervix, then it's diagnostic of cervical circulage. And also post speculum examination, if you can use the Hegar's dilator, obviously it's also one of the preconceptional thing. So what do? Again, you have to stabilize the cervix. Okay, so you give progesterone, and surgical is the mainstay, where do you have two things. So what is the major thing? You are supporting the weak cervix by doing a suture around it. So when you can do a suture, again you can do a prophylactic surplus, provided she is a known case of recurrent abortion for the same cause at 14 weeks or 2 weeks earlier, based on what was the last time. For example, if it was at the 8th week, again you will go with 6 week circulage. Then again, these are the major things which you need to mention, so that you are controlling the uterus so that a uterus doesn't contract. In normal patient, if it contracts, it doesn't happen, but here the cervix is already weak, so you cannot take a chance. So you give progesterone and tocolytics. So MTP, very very sure question, either in paper 1 or 2 or both. Okay, so what are the firstly you need to know that every in and out of it is important, if you ask me as such. Okay, 1 second. In and out of your MTP is important for the fact, because it's an important topic to know, and I'm sure you would have started studying about this from your second year or in your community medicine ka part of it itself. Okay, so let me start with MTP. Okay, so when you can do MTP till now, it's according to recent guidelines 24 weeks. Again, if you have any whether if the board gives permission, you can do it any week. Okay, again up to 12 weeks, what are the things, when are the period when you can do? 1 second. Okay. So what are the medical methods you have and what are the surgical methods you have? So based on that, let us divide what are the possible methods which you can use to do an MTP. So these are the medical methods and these are the surgical measures. I am sure you know about these two, and these are the methotrexate can also be tried. Basically we try it in GTN kind of setting. So this is the protocol. On firstly you start with mifepristone, then after in the day 3 you start with misoprostol and check. You have to examine after 10 to 14 days as well. Okay, then if it's not working, then you have to go for either oxytocin to induce labor, or surgically you have to go for DNC or hysterectomy. So what are the complications of MTP? Make sure you write, you broadly divide it into 3 parts. I have written it so that because it's a short question. So what are the immediate complications? So you can either damage the cervix or you can perforate the uterus, or remote complication, that is near the related to the organ, you can have either obstetric complication or gynecological complication. So these are something, if you read you can understand what are the two things we are giving. So here we are giving prostaglandins as well as oxytocin. So make sure you mention about the side effects of those two drugs. Okay. Now coming to the major important thing, that is multifetal gestation hydramnios. Okay, so this is like one of the favorite question for them. So again the concept now. So I'm sure now related to abortion, I hope you can solve any MCQ also. Then again you can write the same clinic as this. You can follow the same pattern like how we did definition, clinical feature, investigation, then treatment plan, management and investigation. At the end, I have told you that we will revise all the important flowcharts which is present in that part. Okay, now coming to multifetal gestation. Again I'm sure you know it, digozygotic and monozygotic thing. One thing which I want to discuss about all the questions which is there here, no, the problem arises when there is only one placenta. So what happens is, if it's an artery and if it's only one placenta, so imagine this is one placenta and this is the state. So here you need to supply one baby, and here also you need to supply one baby. But what happens is, eventually you might have arterial anastomosis, or arteriovenous anastomosis, or veno-venous anastomosis. Basically veno-venous is very less, but arteriovenous and arterial anastomosis will happen. So that will lead to all these kind of complications, like all these complications. For example, twin to twin transfusion syndrome. For example, blood is flowing from this twin to this twin. So that will lead to anemia, polycythemia sequence, or that might eventually lead to this being an acardiac twin, or and eventually leading to trap kind of setup. Okay, this is the concept. So what happens in only MCDA, that is monochorionic, whenever there is single chorion, multifetal gestation has to be a red flag. Okay, all MFG are considered as iris kid ops, but this is the concept. So based on this, we'll come and discuss about everything related to MFG. Remaining all, everything is the same. So for example, here again, diagnosis. So here there's nothing related to so diagnosis also I have divided into history, symptoms and general examination along with all these things. So again, there might be family history or history of ovulation inducing drugs, and also everything, whatever complications, all medical and medical complications will get exaggerated. For example, she might have excessive anemia, so she might have excessive nausea and vomiting because of beta HCG, or she might have excessive swelling. So any complication, just write excessive in symptoms. Okay, then again general examination, same thing what I told, because preeclampsia is directly proportional to amount of placenta which is present. Okay, again the same thing here, you might have during inspection. This is the main important thing, make sure you mention this and come back. Okay, then again investigation, again to take again aims of investigation, again to confirm your diagnosis and to check the viability of testis and to determine chorionicity. Why do you think it is important? Because to monitor the complication, as I told in the beginning of this chapter, under the concept map, you should know whether it is because the major problem is only having one placenta. Two placenta is fine, because you will have not any other anomalies except malpresentation and all those things. But moment you have one placenta, you are in trouble. Okay, these are the differentials or biochemical things what you are remember. But the major thing is about the complication which you need to remember. Again, when I told you while writing complications, you have to divide it into maternal, fetal and placental. We have placental is much again, but maternal is more. So what are the complications from starting of the pregnancy till she delivers, and after delivery also she will have problem. So again, divided into pregnancy, labor and prepuberty. Again, every complications which you will be studying, you can write it blindly. Okay, because everything will be exaggerated. Again, labor, what is the major important thing? Okay, prolonged labor is fine. Again, major thing is about malpresentation, and also you might have same whatever is you can blindly write all the complication. You can, if you ask me, as such. Okay, but think before you write. Okay, what are the major fetal complications which can occur? This is the major thing, because it's an high risk case, and also FGR, because one baby might grow more or less. Again, you might have intrauterine death and also higher chance of miscarriage. Again, intrapartum management of this we'll be discussing later. It's an important thing. Again, complication of monochorionic twins, as I mentioned, one placenta is creating all kind of problem. So imagine if this is the donor and recipient, you might have twin to twin transfusion syndrome. It's an hemodynamic imbalance due to AV anastomosis, which will lead to anemia polycythemia sequence. Then again, what happens if it's an acardiac perfused in? Again, you might have this tin, here you might have again large. This is the last biggest complication which you can develop. Again, this you can manage by doing a laser photocoagulation. Okay, that thing you need to remember. These are the other things which are mentioned. Okay, conjoined twin is also one of the complication of monochorionic twins, because this is based on when will the division occurs of zygote or blastocysts. So based on this, you might also get this. Okay, poly, again divided into acute and chronic. This is an important question. So again, anatomically it is defined as when it's exceed 2 liters, but sonographically it should have more than 25 liters. 25 centimeter, 5 to 25, right? So if it's more than 25, then it's poly. Again, what is the major cause? Idiopathic. Then again divide it and write it. So what is poly means? The baby is not able to drink. Again, so you can start from head to toe. Again, if it's unable to think, then you might have tracheoesophageal fistula, you might have duodenal atresia, or you might have any neuro related things, for example anencephaly or spina bifida. Then what about the placental thing? You might have chorioangioma, that is whenever there is increased surface area of placenta. Then if it's a obviously multi-fetal gestation, you can have this. Okay, then these are the medical condition which causes poly, which is one of the most common cause. So again, you will divide it whether it's mild, moderate, severe, and these are the clinical features. I'm sure if you can just go through it, you can understand. So these are the management aims. We'll discuss it at the end. Oligo is less than 5. So basically, we are only divided into fetal and maternal. So here, what is the main source of liquor in the baby? It is obviously the fetal urine. So you have to think something related to the renal cause for renal cause under fetal condition. So obviously you have to think about any renal agenesis or something related to obstructive uropathy. What happens in post maturity? Obviously it will start to drink more. So you might have less things, and also iatrogenic and also chromosomal abnormalities. And what are the maternal condition? In all these conditions you can get oligo. Okay, that's it. So I have explained you with the concept. Make sure you study it well. So next, coming to hypertensive disorders in pregnancy, I am sure this and GDM, no. I am sure in a week at least you would have presented either one or both of these cases during your 2 months ka posting. So make sure you go back to your notes which if you have made, and study from that part. Here I have just given you the basic outline so that you will know what to write. Okay, so what are the hypertension? So this, since they had asked what are the classification of hypertension in pregnancy, I just mentioned this. I have mentioned this. The major things which you need to remember is these are the possible clinical questions which you can get. So it might be gestational hypertension or preeclampsia or eclampsia, or she might just have proteinuria, or before diagnosing with pregnancy only she might have hypertension. Again, she might, if the liver is affected, you might have HELP syndrome, and also you might have superimposed preeclampsia or eclampsia. So for etiopathogenesis, I have given you a data diagram and my explanation at the end. Make sure you stay there. Okay. Again, most common in primary gravidia. Here you have to, it's an screening based diagnosis. A preeclampsia patient should always be screened and picked up. If you wait for clinical feature, you will lose the patient or baby. So make sure you are very alert. Okay, these are the initial clinical features which you'll get. But whenever the patient complains of headache or disturbed sleep or diminished urine output and epigastric pain, it's a red flag. So you must think about PIH. You have to measure BP as early as possible. Then these are the investigation. What are the main aim of investigation? To screen for PIH, and if develop, again how do you manage it? And this, why you are doing this? To rule out HELP syndrome. Okay, these are the management objectives. Major aim, I will discuss about the management protocol which you need to discuss there. So again, while majorly you have to check whether she's in preeclampsia or eclampsia. If she's already in eclampsia, obviously maintain airway, breathing, circulation, and start her on Maxelf. Either you can go with Pritchard regimen or Zuspan regimen. Here we use Zuspan. Okay, so because it's just IV, but here you have to go with IM also. So basically this is more convenient than this. And again you have to mention about monitoring of it. Then you need to write about how do you manage it. But if she is in preeclampsia or eclampsia, then you have to, and if she is again hypertension, then you have to talk about labetalol. So basically based on this we'll discuss at end how to go with the flowchart which is given in that time. Okay, when eclampsia is complicated with GTCS, that is called as preeclampsia is complicated, that is called as eclampsia, which we have already discussed. Okay, what are the clinical features? Again you have if you are feeling confusion whether it's tonic phase or clonic phase, what is the full form of GTCS? It is generalized tonic clonic seizure. So never confused, always it is tonic stage first, then clonic. Then if you have not intervened, then she might go into coma. Then again prevention is the major thing. You cannot wait until she develop eclampsia. So again this will discuss at the end as I explained earlier itself. So this is about HELLP syndrome, when that will affect your hematological parameter and liver related thing. So that is something to do with HELLP syndrome. So again we will discuss it. So make sure you remember about the complication here, again maternal and fetal. So major thing is you have to start anti-seizure prophylaxis. That's the major. It's an indicator of your PIH kind of thing only. And also if you are planning to deliver, again you have to start corticosteroid so that lung maturity is attained. Next important thing about the APH, that is antepartum hemorrhage. So you have only major clinical things which you need to think is about the placental cause itself in this. So you have either placenta previa or you have abruptio placenta. Then in the fetal thing, what do you have? You might have vasa previa. So these are the major causes of antepartum hemorrhage. Though there are many other causes, this is the main thing. So again, after what thing we will say as APH, and before what, it's based on 24th week. So if it's before 24 weeks, you say it as early pregnancy bleed, but after that you call it as APH. Oh, here we have explained what are the causes of bleeding. 70% is due to placental cause. Unexplained, again here you can write it as fetus in vasa previa, all those things. And again these are the external cause, basically something related to trauma. Again, any painless APH in a pregnant woman is placenta previa unless proven otherwise. So these are the theories which we have. So though we don't have a proper etiological thing, then these are the degrees of placenta previa. It might be either true, or if it's within the 2 centimeter, then it's called as low lying placenta. Okay. Again sudden onset painless no apparently cause recurrent vaginal bleeding is placenta previa. So again this is the major, pallor is the major thing where you have to write everywhere in ops, provided she has something related to do with blood. Again as I mentioned, the same thing. These are the differential, and these are the complication. You have to mention it properly. Again divided into maternal and fetal. These are the complication because the baby is not getting blood, provided you intervene early. And again during pregnancy, because why does she have malpresentation? Because placenta is sitting at the os. And again during labor you might have cord prolapse or PPH, and also PAS, that is placenta accreta spectra. If placenta is not going into the myometrium, then these are the purpural causes. So again management, again this is the main thing, but here proper idea I have just given. So again you have to do cross matching and start infusion of blood, and if it's an active, then you have to consider stabilizing the uterus by giving tocolytics and start steroids. And if it's less than 32 weeks, again start with Maxelf so that you can give neuroprotective action to baby as well. And if it's nothing to do, if it's not active, then you go with something called as McAfee-Johnson's regimen, where you just monitor the fetus and also the maternal head. Okay, this name is important. This itself can come as 3 mark. Placenta accreta. So placenta accreta is what? Again it's something to do with, if it is painful, then it's a placenta accreta thing. That's how simple you can remember what or the difference between placenta accreta. Placenta accreta is the condition. I'm so sorry. So placenta accreta is when, so placenta has to be always attached to what? Endometrium part of it. But if it attaches to myometrium, So whenever placenta invades, it is called as placenta accreta. So how will you diagnose? Major thing is about MRI. Okay, this is an, if it is an surgical emergency, the patient will bleed like anything. So you need to keep everything ready. It's also one of the complications, which are one of the cause of PPH. So you have to go for hysterectomy. Counsel the patient. If the family is already done, it's better to go with hysterectomy. Okay. The abruptio placenta is something which I wanted to discuss. So it is what happens here. The abruptio placenta. What does the name say? The placenta is getting abrupted. So abrupted before it has to get abrupted. Okay, what are the three types? That means it has to, when has the placenta has to abort during the third stage of labor. But if placenta gets aborted before that, then it is called as abruptio placenta. So these are the three parts, that is concealed, revealed, and mixed. That what does concealed mean? The bleeding is happening inside and you will never know. What does revealed mean? The patient is bleeding actively. Mixed, the most common type is mixed. And these are the grades. Again, while remembering the grades, as I told, first remember grade 1 and grade last. So here you will have no clinical feature. Here already the fetus is dead, and here you will have slight bleeding and you will have medial bleeding. So that's how you remember. Okay. So these are the clinical feature. Management will discuss at the end. Okay. Again, what is cavalier uterus? This is a 3-mark question. I'm sure you can just read and go off. There's nothing much which I need to discuss again. Okay. Okay, now the major thing. Okay, again here, this is the major topic which I wanted. This is one of the major topic which we need to discuss. That is medical and surgical illness complicated the pregnancy. Okay, so what are the major things you need to discuss about anemia? You need to discuss about GDM. You need to talk about NYHA classification and what are physiological thing, and also something related to HIV also we will talk. Okay, the major thing is this is the causes criteria for physiological illness. This is RS2 type of question. Now I don't think they will ask. Just I have mentioned. Okay. Again, what is asymptomatic bacteriuria? That is, there is no symptoms, but also there is more bacteriuria, that is more than 10 to the power of 5. In a normal patient, we will never intervene. But since it is since it might cause preterm labor and other related complications, so you here even in the asymptomatic bacteriuria, you treat the patient with nitrofurantoin and also cefaxilin for 10 to 14 days. Okay. Again, if it's recurrent, then you need to consider other antibiotics also until 3 months ka postpartum. Okay, nothing else. This if you study you can understand, but I have discussed with the concept. Okay, how do you manage HIV mother? If she is HIV positive, you have to divide everywhere in OPS. You need to divide. The major thing which is important in OPS is the numbers, the dose, and the division. Okay, so again you need to talk about prenatal cause, prenatal care, antenatal care, intrapartum and postpartum, as well as how do you reduce the transmission from mom to child. Okay, these are the prenatal care, that is you will do testing, and if it's also if it's seropositive, then obviously you start on ART. Again, in antenatal care, you have to be very cautious about the side effects of drugs and also any anomalies. Okay, these are the major things. Just remember this and forget everything. And also intrapartum care, what you will do, you have to you have to check for viral load, and if she is having more viral load, then you obviously have to start her on IV zidovudine, and if less, then it's fine. Then again you have to be all your instrumentation thing where you can bleed much and where it can go and infect baby should be avoided, because you need not travel. Again, your fourth component or fourth principle is reduce the transmission from mom to child. So again you have to cancel all those things. Again, any cut related thing you have to stop. Again, neonatal care, ART has to be started regardless of breastfeeding within 4 hours of delivery. Okay, again, since it's a low risk, you have to start on breastfeeding, I think. Again, related to contraceptive, you have to prevent transmission, so you have to use barrier method. Since drug interaction is common, again COX are not has to be avoided. Okay, anywhere, but you have to use condoms. Okay, then again heart diseases. Again, what are the physiological things? This independently can come as 3 marker or 5 marker. So again, these are the physiological things. What happens, either you might have first remember hyperdynamic circulation, which in turn indicates increased cardiac output. Again, you might have ejection systolic murmur, which is normal, and again you might have shift of ventricular apex. Okay, and also you might have clinical features like dyspnea. Again, NYHA grading, it's the same thing which you study in medicine. What happens here? It's normal. Here it's severely compromised, and even at rest. Here it is slightly compromised and it's markedly compromised. Remember that, and it's enough. It's an independent treatment. Again, how do you manage heart a patient with heart disease in pregnancy, again if she has pulmonary arterial hypertension, it's a contraindication to have a pregnancy itself. Okay, it's danger to mother as well as the fetus. But if other cause, then these are the protocols which you need to follow. Obviously you have to we have to try for a vaginal delivery, and you have to reduce the cardiac output so that she doesn't land up in heart failure. This is the major things. I'll just return there, make sure you go about it. This is not that important topic, such I have mentioned, so that you don't miss anything. Okay, GDM, sure 10 or 5 marker, or you might get as short or long case in your final exam. So again, I'm sure you know it. Same principle here I have just mentioned. How do you go about it? These are the options which you have to manage a GDM case. And again, you will start. What are the drugs which you will start? I'm sure you know it. I'm not discussing much. I have provided you the template, so make sure you just follow it and come back. So and also one more thing, complications is not equal to effects. Effects might later lead into complication is what I wanted to suggest, because in the 10 marker question they will ask you both effects and complication. Okay, so make sure you divide it accordingly, place it. Okay, whenever you are writing effects, make sure you write it what will the effects on the maternal side, fetal side, and also neonatal side. An important thing, anemia. So anemia first, you need to talk about the most common causes, iron deficiency anemia, but also you need to, when they ask you about causes, you have to talk about physiological causes, 3 criteria which I discussed, and also an RS2 question. Make sure you just see it and come back. And also these are the pathological causes which you need to remember, majorly being iron deficiency anemia. Also all these things. Again, what are the investigation? You have to know the degree of anemia, type of anemia, cause of anemia, and also how do you manage it. Okay, this is the most common thing. I am sure in and out you have studied in medicine, and the medicine also concentrates morely on anemia itself. So we have discussed that there itself, so I am not discussing much on it. Again, complication part, again divided into, why I am not, again you have to divide it into maternal and fetal. Again you have to divide it into this all comes under maternal. This is one thing which comes under fetal. Anywhere in obstetrics you need to divide, if you ask me, maternal, fetal, or placental. So you need to again write about the prognosis. Again, this is the major thing. Okay, spacing at birth. That's why they say you must have minimum 2 years gap, so that because iron is lost during your PPH also, during your labor also, and also during lactation. So it's not ideal. The next baby will get affected by nutrition. Though now we have a good nutritious women in society, but again we need not take risks. So these are the things which we do to prevent iron deficiency anemia. Again, management protocol, we'll discuss it. So these are the major things. Okay, we'll discuss it. Now after studying all this, already we are at the 52 page. These 50 are very high. You will get 2 or 3 questions out of 6 questions from the part 2, from only these part of things. Now what we discuss is as a easy narration. There is nothing for me to explain. You have to just study the notes and go, so that you get good marks. Here I will just give you some flowchart so that you remember and go. So what are the causes of anemia? Any causes, you have to divide it into physiological and pathological cause. Just place it and come back. This is the examination part. In and out, I know you know it. I am not discussing. Okay. Preconceptional counseling, what are the major things you have to start? I know everybody and anybody knows about the folic acid part, but also you need to screen about think about if she has any chronic medical condition like diabetes or hypertension, and also immunization status, and also STD thing. This I don't know, you are studied in comments, so I am not discussing. Again, these are the same objective. This in and out, I am sure you would have studied, so I am not touching only on that. Again, just to go through the notes, there's nothing else I need to explain. So how do you do check for fetal well-being? Again, you can do what is DFKR, that is daily fetal kick count. It's not R, it's C. Okay. Then how do you check for fetal well-being? Again, you have LS ratio to check for lung maturity. Again, you have biophysical things. What does biophysical things means? Again, you are applying biological thing plus physical. There's something activity that is in NST and ours biophysical profile scoring. So that's what they are trying to say. And also, what about the NST thing, where you are going to monitor fully for your pregnancy related pregnancy ka NST is what, where you are going to monitor the fetal you are doing fetal ka surveillance. So how do you write the indication? Again, while writing indication, you have to think terms of maternal indication, fetal indication, though fetal you are monitoring, again some maternal causes might warrant you to check for your NST. Okay, and also placental thing. Again, what are the two things in placenta you know is placenta previa and you have abruptio. And again in fetal thing is if she has FGR or post-dated or oligo or poly, every condition you can write. Again, if it's reactive, that is reassuring. What is reactive means when two or more acceleration is present in 15 beat for 15 seconds for a 20-minute observation. So it's an important question which you are already studied. So again, what does non-reactive means and what you will do? I'm sure you would have studied. So what is modified BPP? First, before studying BPP, study about modified BPP. So it says NST plus AFI. Again, this as the same thing. Again, these are the two things which you'll remember. So again, here you have to talk about the CNS part of it, that is gross body movement and fetal muscle tone along with one respiratory thing. So make sure you know it and you just present in the same. Okay. Hyperemesis gravidarum, it's a 5 marker or a 3 marker question. What you have to basically look for is complication. They might independently ask you to know it for 3 marker. Okay, again while writing complication, as I told, maternal and fetal complication, again these are the complications which you need to just mention, and management principle aims. So firstly you have to maintain hydration, then you need to correct a fluid and electrolyte, then you need to control vomiting using doxylamine and pyridoxine. If it's not improving, then obviously you have to try with chlorpromazine, and if it's more than 10 weeks you can give ondansetron also. And also if she is vomiting well, what is the important things? She might have a thrombosis also, so you need to give a thromboprophylaxis in those cases also. Then this is once they had asked, so you can just mention about how do you manage CSRX. Okay, that's it about part 2. See, 60 pages are there. Okay, the major thing is if you know part 2 and part 3, I'm sure you will pass. Okay, remaining things, I'm sure in your postings or other things you have a general idea, so that you can just know what are the important things. Now under part 3, these are the questions which are there. Okay, so again you have 5, 4, 6, 7, 8, 9, 10, 11, 12. Okay, 6 questions if you cover 12, and these are the most important things, though these are like 3 marker topic. I'm sure you can just go through it. Okay, first about normal labor, I have made a detailed video about labor and how do you do in the management part of labor. First, this channel was started only because of that is OPD approach and ward approach, all those things. So I have discussed extensively about only labor, about only gynae condition, only about obstetric condition in that part. So I'm not discussing much part here. And here the aim is just to provide you notes and make sure you know how to study it properly, and make sure you highlight the same things which are important to be highlighted. Okay, so these are the 5 marker and 3 marker which are present. Again, stages of labor, I am sure you know it, and these are the mechanism of labor. I am sure in and out you will have already, I think many would have already assisted in some deliveries also, so I don't think I need to discuss anything about it. So what about in asynclitism? Make sure you know the clinical significance. If it's mild, it helps in engagement, but if it's severe, then it might cause it's suggestive of CPD, that is cephalopelvic disproportion. Remaining else, I'm sure you know it. Then what is brand induced technique? It's a technique which is there to remove the placenta so that PPH is prevented. Okay, so this is the procedure and this is the clinical significance. So what are the signs of placenta separation? Make sure you divide it and write. That is, you might have a gush of blood, or you might have lengthening of cord, and also you might have uterine sign, like all these conditions. Then about lower uterine segment, it's RS2 question, man. I don't think in this era and this stage they will ask this, but I've just mentioned, so just know about it. The difference they might ask. I'm not looking at. Coming to preterm labor. Again, when do you say it's preterm? If it's before 37th week, again you have early preterm, late preterm, again you have very early preterm. So those are the classifications which you should know. These are the two important things which in and out you should know. Okay, so etiology, again if you might have an iris condition, or you might have a complication in the present pregnancy, like it might be a complications of due to mother or fetus or placenta. So make sure you know about it. Then how do you, again, then clinical evaluation, you get at examination findings, and just mention about all these things. These are the major things which we have discussed already. Then the major thing is you have to prevent. So what is the concept is, 1 second, less than 32 weeks, if you are planning to go for an induction, then you need to give max self. If it's less than 34 weeks, and you need to also 37, sorry, you need to also give steroids. But steroids need 48 hours so that proper lung maturity happens. So anywhere and anytime, even if you are started on this, so you have to already, so you should also start with tocolytics and progesterone. So you need to stabilize the uterus so that it won't go for contraction. This is the major aim in labor. Okay, anywhere and anywhere. So it's a preterm labor. So you obviously need to assess the gestational age and confirm whether it's a real preterm labor or it's a fake preterm labor. Then if you need to stop, if you are, there are no any contraindication, fetus is good, mom is good, then you need to start with all these things. And also to prevent secondary infection, also you start with prophylactic antibiotics also. And this is how you manage. Again, what is IUFT, or it also it's intrauterine fetal demise. So after 22 weeks, otherwise it is called as abortion, right? Then also it has to be more than 500 grams. So these are the causes. Whenever you are writing causes, what are the three things which I have mentioned? Maternal, fetal and placental. Also it might be due to iatrogenic cause, for example an external cephalic option. But what is the major thing which people forget? You have to mention about unexplained. 40 to 50% of the cases are unexplained. So make sure you also mention about it. Anywhere you can mention all the complications. Okay. And this is how you do a diagnosis. I'm sure you can understand it. This is the major thing. What is the major thing? Cardiac for a 10-minute period under careful observation. And also Doppler should be negative. Again, how do you go with investigation? You have to write the aims again. Make sure you write all these things. Management will discuss. Major thing in IUFD management is how do you deliver. Whether you wait and watch, whether you augment it, or whether you do a C-section. So based on this, we'll discuss the management. I am discussing all the management at last because these are very high, so that you revise it again. The major things will revise it again, and you will have a proper knowledge. Because since revision is the only key. Again, Spalding signs, I have just mentioned it. What happens is if there is overlap of fetal skull, it's called as Spalding sign. So this will help. This all the forensic clinical importance. Okay. So make sure you just study that. These all are RS2 kind of question. Since I prepared this notes before exam was on, so I just made sure everything is there. Okay. Again, what is complicated pregnancies? Major thing is you need to study about this. Okay. Then what is TOLAC? Trial of labor after C-section. So again you have RCOG guidelines, ACOG guidelines. If you can study these things. Okay. Again, if what is the basic idea is, if she has no maternal complications and no fetal complications and no placental complications, you can try for TOLAC. That's the overall idea. Okay, that's what I would say. Then based on that, you can just place this and come back. Again, this is like 3 marker, but basically an important topic in pediatrics, which we'll discuss later. Okay. What is post cesarean? More than 42 weeks. It's called as post cesarean, right? Yeah. Post dated pregnancy is more than 42 weeks, but post cesarean pregnancy is that occurs after a previous cesarean delivery. Okay, this I will make sure I will see what it is and I'll come back. Okay, even I'm not sure. I think it's a pregnancy that occurs previous. Okay, I will just see about C2. Okay, major. Okay, this is just an RS2 question, so you can conveniently forget it, but I will explain you later also during our second part of video of the same thing. As I told in medicine part 2, we will discuss about it. And what is RH isoimmunization? Major thing is you should know. Definition I am sure you will study. These are the causes, again due to transfusion, or this is the major cause. Even this can cause your this thing. So I just mentioned it. Again, prevention. active immunization. If she is already exposed, minimize the exposure, and if it's already exposed and having complication, minimize the complication. So these are the major things. Again, this is something which you need to remember at 28 week. And to minimize, again, what do you do, why do you do an MCA, all those things we'll discuss. Again, this will discuss. The major thing is check whether she is sensitized. Then if she is sensitized, check whether she has referred prophylaxis. If not, check for complication. If complication is checked there, then how do you manage it? So based on this, we have the management protocol which we'll discuss. Again, indirect Coombs test, where you will do all those things, is the major thing which you need to remember. Then contracted pelvis, basically CPD is important, and types of pelvis like 3 marker for RS2 kind of thing. So this I have written a diagram, you can just go through it. So whether CP is equal to CPD? Never. Contracted pelvis, you can never have a normal delivery at all, but in CPD it's a relative term with respect to your pelvis and the baby. Now you might have CPD, but in the next pregnancy you might not have it. But CP, if CP is present, it's always you can never attempt a vaginal delivery. Again, for diagnosis, basically all we do is basically what we do is we try for a trial of vaginal delivery. If you have a prolonged labor, all the things, then again we can do clinical pelvimetry. Then we can diagnose it. Though for exam we'll write this, nobody go for imaging and encephalography. Okay. Then trial of these are important, but these are not asked such many times. So I'm providing you the notes, you can just go and read up. I'm discussing only important things. Again, trial of labor, these are the successful outcomes. This not repeated, so I'm not discussing it. Again, this is 3 marker thing. Okay, what is band sling? Again, what do you do, how do you prevent, all these things you can just read about it. There's nothing much. And also, how do you differentiate between constriction ring and band ring? Okay, this is a proper 5 marker or a 10 marker itself, that is about the breech presentation and deep transverse arrest. So how do you go about it is something which you need to know. Okay. So what are the two important, these are present, these are just as for RS2. So if you have time you can study, but it's left to you. Make sure you study this and this. Okay. So what is deep transverse arrest? That is the baby is unable to come down. So this is the definition, these are the causes, and how do you diagnose? It's a clinical diagnosis, there's nothing else. And again, for breech presentation, what do you do? This is a 5 marker. Again, we have discussed how do you manage it later. Breech presentation, there are two things, that either it can be complete breech, that means it's already flexed, or you can have incomplete breech. And also, what in incomplete breech, what will be the presentation? Either you might have frank, that is extended legs, or only foot link, or you might have knee presentation. These are the major things. While writing etiology or writing complication divided into maternal, placental and fetal presented. Okay, this is how you do a clinical diagnosis, and what are the difference between complete breech and frank breech. Again, how do you go about it? That's you go about it, ultrasound. And also, this is the mechanism of labor. You need to discuss under 3 parts. That is, you have to discuss how do you deliver the buttocks, then you have to discuss how do you deliver the shoulder, then you have to discuss how do you deliver the head. So based on if it's a buttock, you need to know what is the engaging diameter. Then also you need to know how during internal rotation how much of the circle it rotates. And also regarding shoulder, you have to discuss about what are the maneuvers. Again, you have many maneuvers here. What are the maneuvers we do, and how do we deliver it? Basically, at the end, how do you deliver the head? Okay, now though all under iris consent, you go and do a C-section. This is something which they used to do. Now, even if you ask me breech delivery, nobody from the patient part itself, nobody will be ready. But again, you can attempt if they are okay. But in this stage, it's very less. But as a question, you should know. Again, what are the indications for cesarean section in breech? These are the indications. And how do you do a vaginal breech delivery? Again, what is assisted breech? Again, you are using any instruments or something. What is breech extraction? When entire body is extracted by obstetrician itself, that is the delivery is not happening, but you are pulling it. That's called as breech extraction. What is assisted breech? Again, I told you, these are the principles. Again, the same thing. How do you go? You have to talk with respect to leg, you have to talk with respect to arms, and how will you deliver the after coming it? Again here you can use forceps, or you can give malar flexion, or you can use Burns Marshall method. That is allowed to hang on its own weight, so that due to gravity it can come down. Okay, this is one of the maneuvers which is used to uh, deliver the baby itself during one of the breech delivery itself. So these are the principle, these are the advantages, and this is the procedure. See, first we'll rotate one part of the shoulder, 1/8 of it. Then again you will try extracting the posterior shoulder first. Then again you will have the baby, you will leave the baby to leave back. Again the same technique, that is Burns Marshall method, so that is one of the delivery after coming head. How do you deliver it? Okay. Again ECV, that is external cephalic question. One thing this you have to write in mind. Again, as your C-section, you have to be ready with all your OT things, so that if any complication happens, then you should be ready. You should be in a position to go for an immediate C-section also. These are the causes of failure. Cord prolapse. Again, if you see an umbilical cord, that is during labor, that is nothing but cord prolapse. Again, these are the causes. These are the types that might be due to occult, that which you cannot see, but you are going to see in the ultrasound or in the C-section. But what about if you can see it? That is called as frag cord collapse. Again, these are the causes. Whenever I told in obstetrics, again dividing maternal, fetal and placental, and write about it. This is how you diagnose. Again, management protocol we are going to discuss at the end. See, cord presentation is different, cord prolapse is different. That's what I wanted to say. Again, prolonged labor, obstructed labor, dystocia, and what are the fetal anomalies? Obstructed labor is something, the labor is obstructed. Again, you might have there might be fault in the passage, that is either in the CPD or cervical dystocia, or the passenger might be faulty, that is he might be in the malpresentation, or something related to other condition like multifetal gestation and all. So these are the principles. So you should know. You should know whether you need to go for a C-section or a vaginal delivery. Again, if you are going for the vaginal delivery, you should know what are the complications. Again, you need to control the sepsis and all those things I have just mentioned. So make sure you just study. It is fetal macrosomia if it's more than 4 kg. That is called as fetal macrosomia. And what is anencephaly? I'm sure you are studying from first year, so I don't think you need to know about this. Again, shoulder dystocia, that is during delivery the shoulder is obstructed, so you are unable to do a shoulder delivery. So that when you go with all these maneuvers, you can try. Again, you can remember the mnemonic helper. I'm sure you know about it. So make sure you study them. First you go with suprapubic pressure. Again you go with McRoberts maneuver. Again you go with Scoots maneuver. Again you go with extraction of posterior arm. Then you have force position, that is like this. Then you have Zanovaris maneuver, where you go push back the fetus and go for a C-section. Make sure you remember it. Whether it's the same mnemonic. Yeah, I don't think. Make sure you remember it. I'm not sure whether it's used for the same thing or something else. Remember it, okay? See, I'm not explaining everything here because it's just a video where I'm guiding you to know what to study for exam and what not. PPH, I'm sure this was your favorite question. PPH and AMTSL, I'm not discussing anything here. I will just give you the broad idea. You just read it. Again, what are the etiology? 4 T's. That is atonicity, traumatic, retained tissue like placenta, and might be due to blood clot. Again, predisposing features factors is not at all required. These are the prevention. If you have time, if it's a 10 marker, you write. Otherwise, don't write for 5 mark or 3 mark. Okay. And management principles, this is the main thing. First, you need to show during management what you use first. First, you try with medical management. Again, at the last, you go with ergometin, which causes continuous contraction. Then you go with what is called as tamponade, that is balloon tamponade, using Bakri thing. Then again you go with blood vessels ka suturing. So this is how you broadly go. Based on this, we'll discuss at the end what to do. Again, if what do you do if it's a retained placenta? Again, you have to check for again placenta creta, increta, and percreta spectrum, and then you need to do check whether patient is in shock or hemorrhage. Then you need to plan accordingly. Again, I'm not discussing any part of it because I'm sure you know it. Again, other end placenta, I just mentioned it in the same. Again, injuries to birth canal, these perineal tears are something which is very important. And again, how do you manage a rupture of uterus? Again, basically the patient might die due to hemorrhage, right? So you need to start all the transfusion related thing. And again, if nothing happens, you have to go for hysterectomy. These are like 3-marker questions. I'm sure you have studied all this in Pharmac. So make sure you study accordingly and place the things and come back. While writing anything, you have to write about the indications, contraindications, any adverse effect, any pharmacological thing. I mean, these are the things. I'll just and also preparation if you want. I'll just mention it so that you go accordingly and you use it. Okay. Induction of labor, again indication, complication, adverse effect. Make sure you know it and you just present it and compare. Partogram I have not discussed and I have not mentioned also. Make sure you study it separately. Cervical rate, Bishop's score. Again, one important thing which I would like to say is operative obstetrics. This can be again part of gynaec also. So I have not included this in this topic itself in the in our PDF itself. So make sure you study all these things before going to this exam also and next exam also. Okay, 1 3-marker will be from this itself. So make sure you study that. Then now you have finished major 2 topics. See, the major topics you have finished in 108 page out of 151. So remaining 3 things is something which is as an easy flow and you have studied in pediatrics also and from second year. So these are the topics which are there. So let us finish it off firstly. So November period again might ask for 3-marker or they might not ask. Physiology of lactation, I don't think we are in that age to ask this question. We are not studying first year. Again lochia also, this is a 3-marker. Again first rubra, serosa and alba. Then abnormalities, again you will have sepsis or pyrexia. That means the temperature might increase or she might go into septic kind of shock. Then what is subinvolution? If it doesn't come back to its own size, that is uterus. If it doesn't come back to its own size, then it is not involuted. So that's called a subinvolution. These are the factors. Okay. This comet thing I'm not discussing. If you want to study, you study. Again, it's as for 3-marker, but as 10 step. I would not study this if you ask me, because I'll write some general things. I'll get 1 mark or 2 mark. I'm happy for that. I mean, it's very difficult for me to remember all the tension, and I don't think I need so much marks. And again, advantages of breastfeeding. Again, while writing advantages, then this again, these are the major things. Again, divided into maternal, then fetal, then for both. So basically under this you need to discuss about it. But here we are also talking about the composition and what are the things which you can do. So while in pediatrics it's also better to write like this. But here I have just given you an idea on what are the things which are important so that you place it accordingly. Again, what are the benefits over formulaic? I have just mentioned. Again, FGR we have discussed it earlier. Again, management things we'll discuss later. So these are the causes and how do you manage it. So major thing is people forget about this, that is constitutional and age more than 40. Make sure you remember that. See, that's why knowing statistics is important. Complication, again divide it into same way and just present it. Okay. Again we'll discuss it the last thing. Again, this is something to do with peds, everything. So problem is this can come independently as 5-marker under Comedica part. So I've just mentioned it. Make sure you know it. Okay, these are the causes. This is how you identify it, and this is something which we'll discuss in pediatrics in subsequent classes. Okay. Again, meconium aspiration, again to do with pediatrics. I'm not explaining. Cephalabetoba and caput succedaneum is also something to do with that. Make sure you study it from there. Okay, this in and out, I'm sure you would have studied in comment, but if you not, make sure you just revise it a day before exam. And these are the measures taken to reduce anemia. Again, perinatal mortality, again the same thing. Okay, now coming to your first part, that is basics. Though these are the questions which are there, first thing and this thing has no questions which are asked, and again sixth thing has no questions which is asked. So basically you need to study 1, 2, 3, 4, 5, 6. Okay, these are the out of 6 things you will get 3 questions. Okay. Again, functions of placenta, make sure if you this is for a 3-marker question though, so make sure you know the 6 points so that you remember at least 2 things. Again, for nutrition and excretion, everybody will remember. Again, respiratory thing and the endocrine related thing, and also the barrier part is something which you need to do. Again, AFI, these are proper 3-marker. Okay, 3 markers are the questions which are will be more in first and fifth and fourth point. Again, part 4 might have 1 or 2 5 markers. So study it accordingly. So measurement insertion of cord is something if it is inserted at the end. So then you have again increased risk of vasa previa and all those things. Okay. Fetal circulation, once they are asked, I feel Nelson has a good diagram than any other books. Okay, make sure you study that diagram and place it at comment. Again, what are the physiological thing? Again, this thing even from physiology you are studying. So again, divide it and just place it and come back. This is the weight gain thing which you need to know. Again, what is this is true labor ka contraction. Okay. Diagnosis of pregnancy, again these signs are something which is important and independently can be as per 3 markers. So make sure you study those signs. Okay. And I'm sure you have one or the other way to remember all these pelvic signs. So I'm not discussing. I've presented in the way so that you have a proper notes to revise. Again, fetus in utero. Again, lie, attitude. I don't know. From second year, they are asking this question. So I don't think I need to explain it. So know the definition and know the proper Lipotsman. Okay. Again, molding. These are the diameters of skull which you know. Under part 5, this is the main important topic. One question related to your contraception is also something which is sure. So make sure you study it accordingly. Again, Pearl index, something to do with comment. So remember the formula and what are the uses. Again, lactational amenorrhea. So these are the 3 contraceptions which you can use along with lactational amenorrhea so that you will not have a conception. Okay, these are the special topics in obstetric. Causes of renal failure never asked, man. Once RS2 it was, so I just mentioned it. Again, causes of DIC, again you have to divide it and I just mentioned it. And imagine an obstetrics, again, what are the things which you know? Again, amniocentesis, chordosynthesis, or something which is important. Again, amniocentesis can be done for diagnostic or therapeutic purpose. Therapeutic purpose, again, it might be again due to something related to blood transfusion or something related to poly or oligo. Something related to that you can mention. Again, for diagnosis, again you need to check for any genetic anomalies, for that which you do karyotyping and all those things. And also late is for fetal maturity. And again, what is the importance of first trimester scan? Remaining all is basically the things which I told is important. Again, operative obstetric, as I told, this in and out I will be discussing under gynec part. I have not mentioned it in this part wantedly because obstetric is more when compared to gynec. So I have not discussed all here, okay. But these are the things which I told I'll be discussing. I will be mentioning you about the last. Okay. Again, how will you go with ectopic pregnancy? In and out we should know. Again, always be ectopic minded because you lose the patient if you miss an ectopic pregnancy. Again, either you might have some clinical features or you might have no clinical feature. When you have some clinical feature and beta HCG is negative, again you have to repeat it in 1 week. Again, if there is no pregnancy, obviously it's negative, pregnancy is excluded, done. But if you have clinical features and if you have TB, if you have beta HCG which is being positive, then you need to think about you have to do an ultrasound scan. Then you need to know the discriminatory zone. That is, if it's more than 1500 ml, then you might also have a beta HCG which is elevated. So again, you have to check for gestational sac, whether it has any intrauterine sac and also whether any adnexal mass is present, because we are thinking about ectopic. So again, you have to check whether beta HCG is rising and serum progesterone is rising at the starting, because these are the 2 hormones which rises in the pregnancy states. So that you have to think about that thing next. Again, if there is obviously, if you can see ectopic, then obviously there is nothing. Again, you have to treat it on a unruptured tubal ectopic protocol. Again, if it's strong clinical features and if she is already in shock, again you have to do resuscitation and do the salpingectomy. Again, if it's an unruptured thing, again you can go with expected management, medical management, or surgical. Basically, first we try expected management based on your beta HCC, whether it is falling or whether if it's low, and based on the size. So if you have less thing, again you have to follow up with you have to follow up with beta HCC to look for G10, which is the major complication of ectopic pregnancy itself. Then again, these are the things which you also do. Again, what is the major thing at the end? You go with salpingostomy or salpingectomy. So again, for identity form mode, this is a proper gynae related topic under malignancy itself. So I've just mentioned it here. What you do is, again you have to check whether the uterus is again you have to check whether the expulsion is already done or whether the expulsion has to go about it. If expulsion is not done, then you have to suction it and evacuate in selective cases. But if it's if it's inert, then you have to check, you have to correct all the other things. Then you have to think how do you go about it, then how do you remove the uterus. Again you have to give metho, so that you are going to think about it. And again, it has a high rate of metastasis into the lungs, so you have to plan it accordingly. I'm not discussing much about it because it's not that important management protocol when compared to marks. Okay. Then twins, again you need to confirm out this is intrapartum monitoring of twin pregnancy. Again, what are the important things? First you have to check the presentation of both the twins. If both the twins are at vertex, then obviously 50% chance. Then again, if it's vertex, non-vertex, first try for vaginal delivery for vertex, then you can do ECV or something, then so that you can also bring the other baby back to the normal position, you can deliver things. Okay, first always try deliver then if it's non-vertex, obviously if a twin A is non-vertex, that is the first delivery thing, then you obviously have to go with C-section. Okay, first try delivering the baby vaginally, then no metergine is given because it causes severe contraction. So again, the second baby might go into distress, so you will never give metergine. Then again, now you need to assess. Again, you have to start the same thing, lie, position, attitude. Again, you have to start everything. If it's a transverse lies, then what is the major thing? You have to try for ECV. Okay. Then if it's failed, try for IPV under general anesthesia and deliver. But if the lie is already longitudinal, that means it's a normal vaginal delivery. Again, check for whether it's a vertex presentation or breech presentation. Again, it's a vertex presentation. Obviously, if it's a low down, use forceps and deliver back. If it's high up, then use Bentos forceps and again pull the head back. Again, if it's a breech, again you have to go for its breech extraction. First, you obviously do assisted breech delivery. What is assisted breech delivery? As I told you, you will go use some forceps of some things and deliver it. What is breech extraction? Baby does nothing, but you obstetrician go and pull the baby back. That's it. Again, I hope that is. Again, these are the major things, so I'm sure you know it, but I hope you know how do you go about it. Basic thing is, first you should check whether it's vertex or non-vertex. If it's vertex, then you have to try the delivery of baby vaginally. If it's non-vertex, everything fails, obviously it's a C-section. If it's first thing is vertex, then obviously deliver the baby, got the clamp, metergine, you don't give metergine, then now assess whether the baby is in transverse lies or longitudinal lie. Longitudinal lie, assess whether it's vertex presentation or breech presentation. Breech presentation, obviously you can try for assisted breech or obviously breech extraction. If it's a vertex, again think where you will put the forceps. If you are putting the forceps very high, then that is called as high up venous delivery, or again if you are putting the forceps low, that is called as proper forceps delivery. And again, if the lie is transverse, try for ECV. If you fail, try for ICV. Then if you fail, obviously you won't fail in ICV because you are doing under general anesthesia, everything will be relaxed. You can pull the baby back and you can do the delivery. Again, this is the etiology of preeclampsia. So basically, they are talking about how all these things causes vasoconstriction and affects everything. Okay. Don't expect me to teach this also because pathogenesis, I'm sure you know about. Then obstetric manager, this is important thing. How do you manage eclampsia? Again, you have to check whether it's in labor. Again, what are the three things? What is the important statement you have to remember? Any seizures in pregnancy is eclampsia unless proven otherwise. So you have to check whether she is in labor or whether it's an antenatal case, or you might also having postnatal case. So first, since it is the majority, we will discuss what are the major things. How do you manage eclampsia in labor patient? Again, you have to if any medical indications or surgical indication for C-section, then you go deliver it via C-section. But if there is no indication, again you have to you have to induce labor, then again you have to do forceps or venous delivery. Okay, then again if she is not in labor, again you have to check whether fetus is controlled or not controlled. If it's not controlled, then obviously what is the treatment of eclampsia? That is termination of pregnancy irrespective of gestational age. Again, if fetus is controlled, check whether baby is normal, that is if fetal well-being is normal. Again, if check whether baby is in preterm, term or dead. If it's dead, obviously induce labor and deliver. But if the baby is preterm, again you have to do steroid therapy. Again 48 hours you have to wait, then deliver of the baby. If it's term, obviously whom you are waiting for, deliver the baby first. Then again you can obviously you can induce. Again, if epidural anesthesia is required, you can do the epidural anesthesia also. Abruptio placenta, again 3 marker or 5 marker. So what is happening? It's a painful thing. No? So obviously first thing you might have is it's one of the causes of your PPH thing. So again you have to write about the emergency management, and also how do you do the resuscitation part. Again you have to check whether if patient is in labor or not in labor. Again, if she is in labor, again you induce the labor and deliver it off vaginally. But what is the major thing? It's because here it's revealed, you have to do that. But if it's a concealed thing, you don't know what to do. So here expected management of placenta abruption is an exception, not the rule. Because if you are waiting for expected management in the concealed thing, then you might lose the baby and you can lose the mother itself. So in that part, you have to again see which side is better, and you need to plan accordingly. Then how do you manage placenta previa? Again, what is the major thing? You are losing blood. Again, major thing is about the resuscitation part, and this is the major thing where you can go with expected management, provided both mother and fetus has a good well-being. Again, this is what you will do if there is not. Again, you have to check for 34 weeks, 37 weeks and 32 weeks. So based on that, you will start all the things which has to be done. And again, if the baby is ready, again induce the labor and delivery. And if there are any indication for C-section, go do the C-section and come back. Anemia and pregnancy. First you need to know first you need to diagnose what kind of anemia is it, and whether any hemolysis component is there or any infectious part is there. Obviously the major thing which we'll be doing is MCV thing. Then you have to do iron studies. Then you have to check if there are any hemoglobinopathies. So but this is the major thing how 90% of the case goes, this thing. So basically you will have iron deficiency anemia. Then you have to know whether it's less than 30 weeks or 30 to 36 weeks and more than 36 weeks. 36 weeks because you obviously will lose some blood, 500 ml to 1 liter of blood. Obviously you have to give transfusion. And if it's less than week, you can try for oral thing. Again, if she's not tolerant, obviously you can go for parenteral. But 30 to 36 weeks, since you will be delivering in some weeks, so I have to go for parenteral. There is no scope for oral. So these are the other things. If you have any other causes, obviously treat it accordingly. Okay, so know which is more common and place it accordingly. Okay. Then again, how do you manage preterm labor? Again, you have to assess whether it's more than gestational age is more than 34 weeks or less than 34 weeks. So if it's more than 34 weeks, again, if there is reduced contraction, and obviously you have to start, then continue the pregnancy. But if the patient has already gone into active labor, then give tocolytic, stabilize the patient, and within 48 hours you have to plan for a delivery, provided you give both steroids. You have to cover the baby with steroids. Again, check if it's less than 30 weeks, you have to check for cervical dilatation. Again, you have to measure you have to confirm whether she is in true. Problem is you have to confirm whether she is in true preterm labor. So for that we have fetal fibronectin, which helps. So basically, if cervical height is less than 27 millimeters, so she is definitely in preterm labor. So these are the things which you need to talk. Again, as I told, 32 weeks you may have to give Maxelf, and again GBS antiprophylaxis and also tocolytics. But if she is not in if it's a false labor thing, then obviously you ask her to come for a follow-up later. Then again, fetal that how do you do if cervix is not favorable? First you have to wait, okay, no interference, and wait for spontaneous expansion. But when if there are any early deliveries indicated based on maternal request or any other infection, then you have to hospitalize the patient, then medically try to induce and labor using misoprostol gel, and check whether if cervix is favorable or not favorable. If it's favorable, start oxytocin infusion. Again, if it fails, start it again with prostaglandin supplementation and deliver it. But if it's not favorable, then you have to use all these things, and also again you have to deliver this. date. This in and out is important. I'll just mention what are the important things again here. Okay, first you need to assess the genotype. As I told, first thing is you need to confirm. Then you need to check whether she has formed antibodies or not using indirect Coombs test. If antibodies are not formed, then she's the candidate to give her she's the candidate for you to give an antibody prophylaxis. Again, what you do? Again, you must you can either again repeat it and check whether she is again unexposed. If she is unexposed, again give a prophylaxis at the delivery of the baby. But again, when you repeat, if she at 24 weeks and 2 weeks later, again if it's less than 16, it's considered as negative titer. But if she is positive, then you have to monitor for complication. How do you monitor? Again, MCA ka P6 velocity. If it's low, again keep on monitoring with NHT and surveillance. But if it's high PSV, then you have to check hematocrit and to check for intra hemolytic disease of newborn. If it is present, again you have to start with intrauterine fetal transfusion. And also, if lung maturity is attained, try to get the baby back to the earth as soon as possible. Then cord prolapse, 3 markers, so I'm not discussing much. Basically, you have to check whether if baby is alive or dead. If it's dead, you go with expectant management. But if it's alive, then you have to immediately do a C-section. That is the treatment of choice. But again, if CTG is reassuring, try resuscitating it and do a vertex. If it's vertex, again put forceps and deliver it, or do a breech extraction. If immediate vaginal delivery is not possible, then again you have to control, and you should not make sure that cord is it doesn't bleed much, so that she is hemodynamically stable. Basically, major thing is you have to go for C-section. Okay. True PPH, as I told, this is what you have to write. In and out, I'm sure you will write about it, but basically you have to check whether you have to know the cause, whether it's an atonic PPH or a traumatic PPH, because these are the two things which are common. Again, if it's a traumatic PPH, you have to go check where is the bleeder. Again, you have to ligate it so that you stop. But the major thing is what atonic PPH. So at that, you have to start with massage. Then again, you have to do you have to start with all your medical things. If it fails, then you have to check. You have to do a mechanical things, as I told, balloon tamponade, bimanual compression, all those things. Then you have to think for suture, where you can do compression, that is B-link sutures. Then again, surgical things, this comes under surgical things itself. Then again, you will ligate all the arteries, and at the end nothing happens, then you have to go with hysterectomy, take consent and come back. Then this is the management protocol for fetal growth restriction. This is how what you do is, again confirm, check whether what is the fetal thing. Then again do umbilical artery study. If it's normal, again deliver off by 37 weeks. But if it's abnormal, for example, if you have end diastolic velocity, if EDV is already present, then again you need to monitor the baby. But if it's absent or reverse, then obviously deliver it off by 30 weeks by giving the prophylactic steroid dose, magnesium dose, and also GBS prophylaxis. But if it's reverse, then immediate thing is you have to deliver the pregnancy irrespective of the status. And as I told, obstetric parts I have already discussed. So that's it with related to obstetric part. The major thing which I wanted to say is, make sure you study accordingly. The portions of obstetric is huge. You cannot finish everything a day before exam. So you should know what to study and what not to study. That is the major thing. First start with 2, then 3, then obviously 4, 5, 1 will go like smooth. It's a smooth, easy flow. So you never worry about that. If you finish 2 and 3, you are already finished 60 to 70% of the paper. With that knowledge, you can obviously answer 1. I don't know about 4 and 5, but obviously answer 1. So provided if you know 1, you will know 2 and 3. That is the first thing which I want to say. So obviously if you know 1, obviously you know 2 and 3. Then 4, obviously you study in pediatrics, and 5, you are studied in community medicine. So proper core OBG is only 2 and 3. Got it. Again, 3 is part of labor. I am sure in labor room you would have seen at least many deliveries. So though breech extraction, breech delivery, forceps delivery you would have seen, breech extraction and all those things you might have not seen. But make sure you study accordingly, place the disease accordingly, and come back so that you don't miss on any question. In this thing, I have just to show you what to write and what not to write, because I have already made videos regarding OBG itself in a proper clinical setting, so that you know what to do. Here we are given you a compiled note so that you know what to study a day before exam. We do the same thing with respect to Gynaec, but Gynaec has a very easy narration when compared to obstetrics. There are only 5 things, and it follows a pathology order, but obstetric is something which is different, right? So this might take some time, but it's okay. It's worth investing time. So study, and I wish you the best. Thank you.